I've started recording, and now we're going to start. There we go. So now, welcome everybody. We're just waiting for all the participants to join, and then we will get going. So I'm just watching the participant count go up. Okay, so we've got over 100 attendees so far, and more are joining, connecting as we speak. But let's make a start here. So welcome everybody to the Thursday evening Liaison Psychiatry webinar on the 24th of September. This week the topic is frequent emergency department attendance, including what works, the role of liaison psychiatry, and indeed what it's like. I'll just introduce the facilitators. My name is Dr. Alex Thompson. I'm a consultant liaison psychiatrist at Northwick Park Hospital. Joined by Dr. Emma McAllister, the lived experience advisor from the Royal College of Psychiatrists Liaison Psychiatry faculty. Dr. Shami Shetty, a foundation doctor, is helping to organise but is on a late shift tonight, so not with us. And we're also joined by Dr. Joel Richardson, another foundation doctor who is with us and has been helping to organise the webinars. So the format, we've got 3 presentations. We're aiming for about 10 to 15 minutes each to make sure we've got time for questions. We're really keen to hear from all of you in the audience, and while we can't see or hear from you via your cameras and microphones, we can hear from you via the chat. So please, if you can start now, just introducing yourselves, just put your name, where you're connecting from, and start chatting amongst yourselves. We'll give you some topics to discuss as well. We will prioritise for the Q&A session questions that are put in the Q&A box, and you can vote for interesting questions to ask as well as part of that. And then we will finish at 8 p.m. We've never had any disruption so far, but if we were to have any disruption on the webinar, we would simply end the webinar straight away and then restart it. So if you suddenly drop out, just please use the link that you've had to rejoin. Wow, we're up to 150 attendees already. And so now I'm going to introduce the speakers, and this week we have the challenge of organising and speaking at the same time. So I'm going to try and chair and present, followed by a presentation from Dr. Emma McAllister, and we're delighted to also be joined by Rian Monteith, who is an advanced paramedic and a specialist advisor to NHS England, who has done a great deal to advance systems of care and ensure that the needs of people attending EDs frequently are met, not only in her local area but across the UK. So moving on to the suggested topics that you might want to have a think about and you know, discuss in the chat while we're presenting. Firstly, how important is marginalisation and deprivation in frequent emergency department attendance, and to what extent should we be addressing stigma in this area? Secondly, I'd be really interested to hear about your experience of crisis response plans, your experience of preventative care plans. How helpful are they? Is there a difference between the two? Another thing I'm going to talk about is how we define frequent emergency department attendance, and be interested to hear what your local definition is, how you arrived at that definition, and also be interested to see what the needs are and perhaps what your experience is about what drives attendance at the emergency department. would request that in the interest of patient confidentiality and consent, you don't discuss individual cases in the chat or Q&A, but of course you're welcome to talk about common factors. And please also do make sure that you select to all panelists and attendees in the chat, because otherwise you just end up chatting to the panelists, and I think until the Q&A, I'm not able to present and attend to that at the same time. So I'm going to start with my presentation, and I'm going to talk a little bit about the evidence and the research around frequent attendance. So I'll think about the issues, the needs, how we define it, and what helps before considering the system level perspective. We hear a lot about frequent emergency department attendance and emergency department crowding and demand and these sorts of things, but it's really important, I think, to keep in mind that frequent emergency department attendance is not responsible for the majority of emergency department demand and need. This graph on the right hand side is from 2016-17. There were nearly 15 million emergency department attendances. Only 1.2% of patients attended 6 or more times, and while this did account for just over 7% of all attendances, it really is a small issue compared to the majority of emergency department demand. What it may be more helpful to consider is the needs associated with frequent attendance. And we know from research both in the UK and around the world that there are a number of common factors identified which disproportionately affect people who have attended emergency departments frequently. I'm most interested in mental health and addiction needs, but there are lots of needs associated with medical conditions, with deprivation, with conditions of marginalisation as well. There are also local variations, and on the right I've identified some of the issues which we have identified within our hospital and some of the things that we have successfully addressed. In particular, we had an issue a few years ago with catheters and nasogastric tubes getting blocked and people coming to the emergency department, and we've successfully developed a catheter service, which means that we see far less of that now. So the challenge with frequent emergency department attendance is that it's quite hard to define. Their definitions seem to be fairly pragmatic. The Royal College of Emergency Medicine talks about 5 attendances in 12 months. NHS Right Care talks about more than expected service use. For the mental health programme, NHS England talks about 10 attendances in 12 months. And when you look at the research literature, there are all sorts of definitions based on per year or per 6 months, which seem to be, I think, based much more on opinion than real research definition or validation. I will come back to this, but I think it's important to consider and discuss this issue. If we don't have a consistent definition of frequent attendance, how can we develop and evaluate interventions to improve care in this area of need? And how can we really consider who it is that we need to be targeting and help? It's also, I think, important to consider patient perspective and patient experience. And I've highlighted that the risk factors for frequent emergency department attendance are often things associated with marginalised and deprived groups. We know from the persistence of language, such as frequent flyers, and from discussions which frame the issue in terms of cost or burden, that people are subject to stigma. When in the small amount of research where people have been interviewed or their experience has been researched, it's very common for people to report discrimination associated with frequent emergency department attendance. So it's really important that we bear that in mind and we consider what we can do to serve the needs of people who find themselves in this situation. Now, just going to summarise types of intervention. There are 6 main elements or service models when we consider approaches to helping people who have attended emergency departments frequently. Perhaps the most passive model is simply information sharing, either ensuring that different agencies have access to mutual electronic records or having regular multi-agency meetings, and that's what we do at Norfolk Park Hospital. More active interventions include care planning, which can be either preventative care planning, where you meet someone and you have all the agencies involved in advance, or crisis planning, which is more about just having a sort of list of guidance for what to do in response to an ambulance call or an ED attendance. Case management is much more proactive, and there seems to be 2 different types of case management, either people working behind the scenes to join up different community agencies but not working face-to-face with an individual patient, or key working and face-to-face individuals where people do actually meet up with the patient or the person who has been attending frequently. So I'm going to summarise a recent systematic review published by Sorrell and others, which looked at studies in these areas. So the first area was record sharing. There's little evidence that electronic record sharing alone was effective, and there was nothing about MDT information sharing or sort of regular multidisciplinary meetings. Care planning as a standalone intervention also has very little evidence to actually support it. There was 1 randomized controlled trial, 2 cohort studies. They didn't find an effect on attendance frequency, but they didn't also report the type of care planning evaluated, whether this was crisis response plans I described, or whether this was preventative care planning. And certainly my local experience is that preventative care plans, where we've actually identified a need, got people together and looked at how we can proactively better serve an individual person, is far more useful than crisis planning, because by the time an emergency has arisen, a person is either on their way or they're in an emergency department already. The intervention for which there's most support is case management, although this is still quite variable and relatively weak. The challenge with looking at evidence in this area is also thinking about the form of case management. Some of it's delivered by psychiatrists, some of it's delivered by key workers, some by allied health professionals, paramedics, social workers, occupational therapists. So there's very little consistency really, which could drive us to, could guide us to think about what works. So the areas for which there's very little evaluation includes the multidisciplinary meetings, MDTs with care planning, training interventions, consideration of stigma and discrimination, and also system level programs where a need is identified in individuals, but then a change is made to a service as a whole. There's also a need to consider lower intensity interventions rather than case management, which could be aimed at people who are attending less frequently, with a view to preventing progression to more frequent attendance. It's also, I think, important to mention that there are some areas for which there is no evidence, particularly related to frequent attendance with mental health needs, where there's no evidence of benefit and there is the potential for harm. Firstly, there's no evidence to support the use of behavioural paradigms which involve not seeing people with mental health needs on the grounds that seeing people would encourage further attendance. Secondly, we're also hearing increasingly frequently accounts of people being prosecuted for alleged offences related to healthcare resource use, often around self-harm or feeling suicidal, such as breach of the peace or wasting police time. Given what we know about the harms of prosecution, there would need to be a great deal of evidence of clinical benefit for this to be justified. And there is no evidence in the research literature of benefits to patients from prosecution. So this is not something which we should be supporting as an intervention. Now, given the limited evaluation of interventions in this area, we do need to consider where do we go next. One of the reasons for not finding much effect in randomized controlled trials may be that if you introduce a care planning or a case management system in a hospital, you're actually changing the system as a whole. So if you're randomizing individuals to different interventions, you may find that you've changed the system and the control group is also benefiting from improvements in care. Another reason that we may not be finding much effect is because frequent attendance may not be a stable characteristic of individuals, but rather it may be a characteristic of the system as a whole. There was a large study in America, in Massachusetts, looking at the whole emergency system across the state. They found that even without intervention, less than a third of people that were identified as attending frequently in 1 year were still doing so the following year. And certainly we've found the same locally when we've looked at people attending frequently without any intervention. We found that they actually, even without intervention, the majority of people identified in 1 year are not attending frequently the following year. So I would suggest that this means that there's an argument to be made for frequent attendance to be considered as a systems issue rather than an issue with individuals, and that our focus should be on improving access to community and preventative care rather than crisis planning or key working alone. This approach and this way of thinking about it has parallels with changes in culture around other areas of medicine. For example, around the culture around bed blockers, where this is now considered a systems issue around delayed discharges or stranded patients rather than an individual issue of problems with individual patients. So putting all this together, I would suggest that there's a need to develop and evaluate a systemic stepped care approach to dealing with frequent attendance and to meeting the needs of people who have family disease attending frequently, which would involve a strong focus on using emergency department attendance data to identify and address areas of need in services, to intervene at a system level to develop services, and then to supplement that with key working and case management for those people in highest need who may still be falling through the gaps. A number of principles must run through such a model, and these would include co-production with people who have attended frequently and their carers, approaches to better fostering of collaboration between different community agencies, and a strong awareness of social deprivation, stigma and marginalisation as well. So, in summary, psychiatrists have a lot to offer for improving care for people who have attended the emergency department frequently. We have experience of multi-agency working, advocacy, holding hope for people with long-term conditions, and addressing issues of stigma and social exclusion. Work to help with frequent attendance must include medical, psychological, and social issues. We must be alive to the pitfalls of seeing frequent attendance as inevitable, or losing our curiosity, or despairing, because it can be very hard to change systems, but not impossible. Finally, I'd like to encourage us to think about framing things as whether they're about demand or burden on the system, or whether they're about patient needs, because if we focus primarily on the needs of patients and the burden on patients rather than the burden on services, then it will follow that demand on the system will lessen. That's all from me. Now I'd like to hand over to Dr. Emma McAllister, the lived experience representative from the Royal College of Psychiatrists, Liaison Psychiatry faculty. Are you ready, Emma?
Yes, I am. Thank you, Alex. Can you hear me okay?
I can. I'll mute and you go ahead.
Great, thank you. Good evening, everyone. My name is Emma, and I'm going to talk about what it's like, the experience of attending the emergency department with mental health needs. Next slide, please, Alex. I have severe obsessive compulsive disorder and previous anorexia nervosa, and over the last 30 years have suffered a number of serious medical consequences requiring emergency department treatment. These have included refeeding syndrome, heart problems, problems relating to self-harm, serious burns, respiratory problems, and more. When I've been at the emergency department, it's often been in recess. Outside medical communities, there can be assumptions about people who attend the emergency department frequently, and assumptions that they're doing so inappropriately and not needing medical care. You, of course, know the opposite to be the case, that often frequent attendance indicates unmet need and sometimes serious medical need. When I didn't have access to the right help for obsessive compulsive disorder or access to treatment, I had 133 attendances at the emergency department in 4 years. But after I had the right treatment and help for obsessive compulsive disorder, in almost 2 years, I've had 0. I've had some great experiences of care, but some so lacking that they cause me serious harm and have left me with permanent disability. I want to frame frequent attendance as need that is unmet, often misunderstood, and can be driven at times by healthcare and other systems, not always by individuals. But first, I wanted to ask you to stand alongside me in a moment of discomfort as I talk about frequent attendance. This is hard to talk about, and I'm sure it's going to be hard to view. Next slide, please, Alex. These are all things that have formed part of a response to me as a frequent attender. They include withholding treatment, sometimes degrading treatment, taking away my clothes, not ensuring my dignity, inflicting pain or not acting to alleviate pain, sometimes encouraging criminal justice interventions, as Alex described, as a consequence for self-harm. I have experienced all of these as an individual. These are horrifying and difficult to view, but please stand alongside me for one more moment to understand the impact that not receiving good care for mental health needs as a frequent attender can have. Because I attended the emergency department multiple times with serious self-harm, I was given a care plan, which meant I did not receive psychiatric help or assessment when I attended the emergency department. This contributed over a number of years to severe obsessive compulsive disorder being missed. Not assessing and treating severe obsessive compulsive disorder had the impact at the time of destroying my career, my professional work, and almost my life. Next slide, please, Alex. Another very difficult slide to view, but hold with me for a moment. These are some of the things that have been said to me in the emergency department with mental health needs. I know no one listening would condone any of these. However, I wanted to draw your attention to one in particular in the bottom right-hand corner, which is the silence of those people in emergency departments who stood by and didn't act when all of this was happening to me. A lot of these were said in the hearing or being witnessed by others, and people did know that this was occurring, and nobody acted to protect me from this as a frequent attender. Next slide, please, Alex. So what can we do? Frequent users need our attention, and there is a significant evidence practice gap. Next slide, please. Frequent users have striking unmet physical and mental health needs. There's evidence that this may increase with increased attendance, certainly for self-harm. However, does the quality of response increase with that increased need? Next slide, please, Alex. My experience leads me to ask you to question your and perhaps others' assumptions. You've all heard the term, I'm sure, known to services about frequent attendance. But what does it actually mean when somebody says that a frequent attender is known to services? Next slide. For me, this has actually meant that the person doesn't know me and is assuming that somebody else knows, but actually nobody knows me. Frequency has been mistaken for knowledge, and curiosity and an opportunity to help has been lost. Next slide. That loss of clinical curiosity defines my experience as a frequent attender, yet we can change this. Next, please. An informal motto of Liaison Psychiatry is turn up on time, be useful. And this applies in the emergency department as much as elsewhere. Speaking to my own experience, turning up in time is vital. The point of discharge, where my medical needs have perhaps been met and I'm now being assessed for whether I can be discharged or not, is too late to often help me from a liaison psychiatry point of view. To be useful, be aware of stereotypes, be more than a binary admission or not assessment, and be aware of role modelling. What is it that other people in the department see? Next slide, please, Alex. We also need to understand the effects of healthcare-based discrimination and stigma. Frequent flyer is a common term for frequent attendance. It's unacceptable. It's a sign something is wrong. As my picture tries to illustrate, I think it belongs in the bin. Mocking patients isn't okay and does affect healthcare outcomes. Next slide. Stigma around frequent attendance is common. This tweet was by a high-profile, very senior emergency department consultant in my area. Yellow triangle patients in my area is the informal, slightly mocking name for people with a frequent attendance plan. That's how it's denoted on the note system. I don't need to explain the rest, I hope. So how can clinicians help? How can you respond when you see this? What skills do your team need? I would say the work of challenging stigma and the work of changing attitudes should not be left to patients. As a patient, I was the only person who challenged this tweet and got in touch with the person at the time to talk about what had led them to post it publicly. And this work should not be left to the people suffering the most from it. Next slide, please. We also need to recognise unmet need. Next slide. Frequent attendance for mental health needs can be driven by a closed loop circle of signposting, a bleak, never-ending turfing from one place to another with nobody actually stopping to help. It can also sometimes be driven by gaps in services and sometimes by service policy elsewhere. And I've tried to illustrate the circle that used to happen to me. Sometimes my GP would call for a mental health assessment. They would instead call for the police, who would take me to A&E, who would or would not instruct or call for a mental health assessment, who would tell me to call a helpline, who would call my GP, who would try to get me a mental health assessment. It just went on for months. So it's so important that we consider, is anybody in this circle actually stopping to meet this person's needs? Next slide, please. For some, the answer to all this is care planning or flagging. The yellow triangle plans, as they're informally termed in my area. However, from my experience, I would urge caution here. For me, having a care plan functioned as a lightning rod for stigma, but with no earth. It made me a target for discrimination within the department. This study in criminal justice found that flagging people with mental health needs in custody actually significantly disadvantaged people. So it's important to question some of our assumptions here and understand the impact that plans actually are having. So how can we help? Next slide, please. And then the next one. We need to stop locating system problems in individuals. We need to recognise what is a system problem and be brave enough to admit that. We need to be prepared to hold curiosity, humility, and discomfort. And that may well include the type of discomfort that you've sat with me through over the last 5 minutes. I'm talking about really difficult previous experiences. Those may well be foregrounded when someone's in the emergency department for understandable reasons if they've had those experiences before. We need to stop closed loop signposting, have zero tolerance for discrimination. identify exclusions before they occur, and act to eliminate exclusions from healthcare systems for people with frequent attendance and unmet needs. We need standards and accountability, and also to understand limits of frequent attender plans. Frequent attender plans are not the answer to everything in frequent attendance. For some people, there is a potential that they might be able to make things worse. Next slide, please. We also need to question the limits of some psychological formulation approaches. Sometimes these center around attachment and assume individual attendance is about an individual's relationship to staff. Yet it's important to understand what actually drives and causes frequent attendance. Some frequent attendance is driven indirectly or directly by imperfect services. Sometimes people will be brought in either voluntarily in handcuffs or brought in non-voluntarily by police. It's not necessarily about the individual relating to staff. Some individuals who are frequent attenders very much do not want to be in the emergency department. It's important to think more carefully and more thoughtfully and more individually about this. So we need to assist individuals. We need to take time, and we need to consider time, not making people wait intentionally. I still come across the idea of a therapeutic wait. This kind of thing should have been eliminated. Seeing people early, often seeing people more than once while they're in the department or while they're in hospital. Timeliness and taking opportunities to help. We need access to treatment and to help, monitoring and eliminating exclusions, avoiding assumptions, clinical curiosity, assessment, access to treatment, adjustments, and considering healthcare and trauma, including that very difficult acknowledgement of previous experiences within healthcare. We also need high standards of care. This is a group of people with significant unmet medical and mental health needs. Guidelines, standards, skilled and competent staff, understanding what's gone well as what hasn't. Forming these relationships, being more than a binary admission or not assessment, and offering assistance and advocacy, not just assessment, as well as hope and help. Ensuring quality care for people who self-harm has the potential to help change the experience of care for a large number of people and make a real difference to their lives. Next slide, please. I'd just like to thank you for listening, and I'll be happy to take questions after Rhian's finished her talk as well. Thank you.
Thanks very much. So now let's move on. It's just gone 7:30. I'm delighted to see we've got nearly 220 people with us, and I'd like to hand over to Rhian Monteith.
Hi Alex, thank you very much. I'm not sure how I'm going to follow that one, but I'll do my best.
You will.
Very kind. Please lower your expectations, everybody. Today I wanted to just talk to you about, frequent attendance is, so I've been a paramedic for about 20 years, and when I first heard about frequent attenders, and I just didn't, probably about 10 years ago, I thought, I just don't know what to do with this group, or I don't know how to help. And it wasn't as glamorous as being an advanced paramedic whizzing around on a fast response car to things. But what I've learned is I've absolutely fallen in love with this group of people because they are completely real. They're as real as you get. They wear the heart on the sleeve, they ask for help. And so I really wanted to put my shoulder to the wheel for the last 10 years in looking to see how we can move forward as a system, as organisations, but most importantly, how we learn from this group. So the reason why, for me, I didn't know what to do next steps as a paramedic is because I hadn't asked the group of people what they needed. And I arrogantly presumed at the time that clinicians knew best, and how wrong could I be? So what I did was spent the next 4 or 5 years asking people what they needed, having conversations rather than consultations, and instead of coming up with a model and then doing it to people, I asked the questions for 4 or 5 years and then used the answers to that to come up with a model called a switch model. And it's fantastic. So the switch model that I'll talk about in a minute has really been used to shape behaviours and mindset changes for a lot of people. So there's frequent attenders are not a cohort of people. They are, you know, that's what we're talking about today, but actually it's not a group of them and us. So this switch model can work on lots and lots of different people. Anybody. Also works on children age 11 and above also. So our programme works by, and this is an NHS England programme that took the work that I set up the first high intensity user programme in Blackpool ages ago, and now it's spread across about 80% of the country. It's also, we also do work with the devolved countries and internationally as well, different parts of the world. So if you're ringing in or listening from there and you like what you hear and you want to have some support setting it up, then just be in touch. So what it does is it identifies people who attend the ED and have subsequent non-elective admissions the most. We describe people as individuals who use healthcare more than expected. We don't tend to have a definition, and I know, Alex, you mentioned it before about having a definition, but for me, when you have a definition, it stops you growing a little bit. It stops you, the more successful you are, the more you've got to shift that definition forward and backwards and sideways. So we just say, look, give us the top 100 to 150 people that, and we'll work with those guys. So we'll pick some people off the list of A&E attendances, and we will just reach out to them and see what we can do from there. It's a coaching approach to change mindsets and behaviours, and we have an online learning, but it's when people think about changing mindsets and behaviours, a lot of people think it's 100% to do with changing the thinking of the people using the service. I would strongly argue it's equally, if not more, changing the mindsets of the people delivering the care. So that's really a really important point, because we're only a product of our own experiences and our own exposure to people and things. So I think that the more you can expose yourself, not in a flash or map kind of way, but you know, expose yourself to people and things, so you know, we can learn. Anyway, we have a phrase that is a demedicalized, decriminalized and human approach. We presume everything is social, so whether people come in, whatever they rock up to A&E with, it's you know, whether it's mental health diagnosis or what their discharge disposal is, whether it's chest pain or whatever, we presume everything is social until proven otherwise, and that's our plan A, and we go in strong with a social and community response. Because by nature of them attending A&E so many times, they've had clinical intervention. It doesn't mean to say that we've not missed anything as clinicians, but we're going to try a different approach, and it works brilliantly well. We never criminalize anybody. If you assault somebody, if you you know, if you do anything like that, then you know, absolutely we treat people unconditionally, and actually what I mean by that is we treat them unconditionally, but the same as everybody else. If somebody came and gave me a punch in the nose, then I'd expect some you know, some boundary setting and some punishment actually, but just like anybody else. But really, we don't punish people that are in crisis. We don't criminalize. In 10 years of running these programs, have never you know, sent anybody to jail. Otherwise, we become part of the problem we're trying to solve. And we have to have a human approach. It sounds really, really simple to be human to people, but it's absolutely rock hard to do. A lot of people cannot be human. They come in and say, tell us all your problems, and you know, we'll help. But actually, if somebody knocked on my door and said, tell me your deepest, darkest secrets, tell me all this, I'd tell them to poke off. I'd be like, no, I don't know who you are. You know, you've got to humanize. I've got to know who you are before I reveal anything for me. So there's a real skill in that. The biggest thing or the two biggest things that people haven't got in this group are they haven't got friends groups and they haven't got purpose. So they might have a lot of services going in and they might have a lot of appointments, but they don't have any true friendships. They don't have the basic human needs met. So that's one of the things we really do, is reconnect them naturally with friends and purpose. And the purpose doesn't have to be getting out of jobs, springing out of bed and suddenly getting yourself a job. It doesn't have to be as dramatic as that. The purpose sometimes is that you ask them to help you with something. So this week, I'm moving house on Tuesday. Can't wait. It's by a beach. And I was asking one of the clients, I was saying, look, I need a new bedside table. Can you just Google it on Amazon? And, I need to, this is my price range. This is the colour I want. This is the style. Can you search it up for me? I haven't got time. I did have time. And I could have a look, and I might have a look at what they send back. But actually, that's given them purpose. They've sent me hundreds of pictures of different things, and I send back saying no, yes, no, try again. But this has given them a purpose of what to do in that day, which is slightly different to normally what you do. What we believe is we concentrate on the people and the results follow. If you concentrate on the data and try and get the attendances down, and that's in the forefront of your mind, is I've got to get the admissions down, I've got to save money, this is a job, and it's not going to happen. So we don't fuss around the data follows. So does it work? Evaluation results. This is our approach is live at 125 now CCGs. We've got another 5 coming up this week. And this has been about a 3-year sort of rollout. The minimum, depending on how close you stick to the switch model, is you get a minimum 60% reduction in emergency department attendances. It's got a really massive drop, 78% up to 78% in 999 calls and police calls. And the biggest difference is that people get better. And they get the results because people get better and people feel connected. So it's a brilliant program. So there's a couple of do's and don'ts that I'd like to go through. A couple of don'ts is not to make it a criminal offence to when you can't cope, because this is what this is about people can't cope. They either haven't got the skills or they've forgotten. Can I have the next slide, please, Alex? So it's really not to judge people by their biggest mistake. I mean, 1 in 2 of us get divorced, and when you get divorced, you do some nutty things and you make some weird decisions. When you lose people in your life, when you lose one of your parents, you go off the rails sometimes. If we do these things in full view of everybody else, and whatever the crazy things we've been doing behind closed doors suddenly becomes really evident on when we book in at A&E, or we go to our doctors, or we go to the party that we get invited to. If everybody knows at that party that we're rocking up, we've got a big list of, oh, Rian did this, Rian did that, Rian did that, then you'd never be invited to a party again. But what happens with frequent attenders is they live their lives in front of everybody, and it's recorded and it's judged. So my plea is not to judge people by their biggest mistake. We've all made them. One of the other points is that when we join a life of service like we do, that we have sort of been plucked out of the air to try and help people, and that gets misconstrued with fixing things and people don't need fixing. So I think it's just sometimes just to be aware that when we join a healthcare role and a clinical role, sometimes that we give all of ourselves away and leave nothing for us. So one of the biggest things about switch is, the switch model is, you've got to do it yourself, and then you could serve other people. Yeah, next slide. Let's just talk about some of the do's. So some of the do's is don't, you remember the don'ts to start with, because once you learn these things, then time goes by, 6 months, a year goes by, and then you default to your old behaviours. So always remember that list of don'ts. And we start from a position with everybody. The biggest thing is we walk into people's houses, knock on the door, ring them up, and just say, this is a clean sheet. It's a clean sheet for you, for me. Let's start from that basis and humanise yourself. So the bits about me saying I'm moving and I'm going, living by the beach, and a few different things, is just a way of adding things in that you might connect might have other people connect with you, but you've got to give a little bit of yourself away to be human. And characters made in the dark. I love that phrase, because it's when nobody's watching and nobody's monitoring. That's when I value character. This is about changing your language as a worker to wake people up and come off script. You've got to do some different things. It can't be the same old conversations all the time and you expect other things to change. It won't unless we change first. It doesn't really matter why people need help. It's some people concentrate too long on why have you done this. If we switch it to how have you got here instead of why have you got here, then it reframes it a little bit so there's less judgment. And the important bit is how we progress from this rather than always looking at the past. So if we skip on a couple of slides, Alex, this is my final slide. So this is I'm just going to take you through the switch model. If you want more information, there's a website just to click on to let you know. But this is there's a model with 6 elements, starting with wake up and it going clockwise and it ending with complete. And these are different modules. Different principles. So the wake up module and the principle of waking up is we've got to wake ourselves up in order to connect with somebody. We have got to switch on. We've got to show up on time, realizing what the language is and having real emotional intelligence when we're doing it. We've got to take notice of people. We've got to take notice. First thing we do when we get a list through the client is look at when the birthday is. If the birthday's just been or if it's coming up, we send them a card. We organise an appointment for that day and offer, say, oh, I don't want to come out for a cup of tea. Oh, it's my birthday that day. Okay, great, we'll grab some cake. And you take notice of these things. What we tend to do as clinicians is we miss out those top 3 stages and we go straight to, how can I help you? How can I serve you? How can we unpick your problems? They're not ready yet. If you don't wake somebody up before you do that, you're going to have the same answers on script the whole time. So you've got to do the top 3 about connecting with people before you start problem solving. Then you unpick the problems one at a time so it's manageable. Then connecting with tools and techniques that can help behavior changes. And then you complete that, either that issue or that consultation, and then you go again. So it really does work well. So that's all from me. If there's any questions in the chats or anything, I will answer them. But yeah, thanks very much for everybody joining on. It's been great to be here today. Thanks, Alex.
Okay, thanks very much. So it's just gone 7:45, so we've got just under 15 minutes for questions, and we've got a few questions in the Q&A. So I'm going to try and chair and answer questions at the same time. Where should we go? So first of all, a question about how has COVID pandemic affected frequent emergency department attendance, and has there been any difference? Do we have any figures? I must admit, I'm not aware of any national figures, and I can talk a bit about our sort of local experience. Rian, do you have any local experience about how the pandemic's affected frequent attendance?
Yeah, I mean, a lot of people, I'll just put it in the answers, but a lot of people have, so you've got a group of people who've always gone to A&E or have been for a while, frequent attenders, and they, like a lot of people, have been worried about going in. So you've got, say, 50% who stopped going in around March, April, May, and you had a big sort of dip in them. And then you've got another sort of 25% of people who have increased there because there's a lot of anxiety, there's a lot of uncertainty, so that they've increased their attendances. And then interestingly, you've got a group of people who've never attended A&E in their life, and there's a massive surge across the country of people losing their jobs, who feel that they can't meet people, there's not connecting. So there's been a huge surge in people who've never been before. One of the other questions I just wanted to say is, I might not have articulated it as well as I could. I've been off coffee for a while and I've gone back on it tonight, and I shouldn't have done. So about the boundaries, this is not around, there's things I talk about are not boundaryless. We have very, very firm boundaries because we need to as workers, but we listen hard. The point I was making was we listen hard to people before we get hard with our responses. We don't condone violence, full stop, or aggression, full stop. So yes, you will get prosecuted just like anybody else if you cross that boundary. But what we don't do is we don't have some people have got criminalizing people right at the forefront of their minds. So they think, do you know what, I'm going to try this, this and this, but I can punish somebody anytime I like. And it's too far at the front of somebody's minds, and then excuse how you come across to others. So that I just wanted to address that. There's just a few comments in the chat.
Okay, thanks. And similarly, our local experience is that the initial stages of the coronavirus pandemic, resulted in a big reduction in frequent emergency department attendance, which I suspect was not for lack of need, but was for fear of attending emergency departments. It may well also be that certainly in our area, our community mental health teams must be commended for really stepping up and investing in 7-day services, putting extra services in place to meet the needs of people with mental health conditions. But things I think are now trending back upwards, and we're aware that we stopped having our multi-agency fora for a little while, but we're back on top of things now. So I hope that things will be fairly stable. Now, there's another question. What happens where everything has been tried in some patients, but it's either not helpful or simply not effective? And would that be a justification for withholding care? I will comment briefly from the perspective of the emergency department and from Liaison Psychiatry. It's certainly not the case that we would expect somebody to be sort of routinely referred on every single attendance, and I think it's also not the case that we would expect someone to be forced to see a mental health team if they declined to see a mental health team. However, I think what those comments were referring to was the situation where you have somebody in an emergency department in need, in mental health distress, and perhaps the referrers, the emergency department staff, are also in need of assistance or advice, and there is a blanket plan to not provide mental health assistance in those circumstances. So I'm not commenting about community care or preventative care planning and these sorts of things. It's more about the approach of not responding to an emergency. I don't think can be justified, and there is certainly no evidence to justify this. Do any of our other panelists have any comments on that question?
I have a comment, Alex, and I suppose from my own experience, as somebody who was also very much painted in that light, that there were definitely conversations about me, and there's stuff in my notes that things had been tried and this was very hopeless. There's even a part in my notes about how my death was inevitable, and it even went to the extent of structuring out what support would be available for staff after my death. And the the kind of the very difficult thing amidst all of that was that there was this very strong narrative around everything having been tried, but even the very basic, very core things actually hadn't been done, like a complete mental health assessment that went on to diagnose OCD, which turned out to be incredibly treatable in my case. So I think sometimes it's good to, you don't have to do a full re-diagnostic assessment every time somebody attends, but I think it's good sometimes to hold on to hope and to have an element of critical reflection around some of these narratives that are maintained around patients. And I think sometimes that's more to do with the amount of discussion that's going on rather than the amount of care and the amount of need that's been met by those individuals.
Thanks. And Rian, any comment on people where everything's been tried?
If everything's been tried, then my opinion is just let it go. Just, you know, let things go and treat people unconditionally. That's my personal opinion, and that's what served me well. So I don't ever go down the advocating withholding treatment or no sends, that sort of thing. I just treat people unconditionally.
Thanks. And we've got a question about what's the evidence to support multi-agency approaches involving mental health, acute trust, police, ambulance services, and also a question about should responses to frequent attendance include contact with people when they're not in a period of frequent attendance to explore experience and future planning? And is there any research about this? And as far as I'm aware, there is not any research, but I think that this does sound like the sort of approach that should be adopted and evaluated. You know, certainly my experience is that proactive preventative care planning, and certainly in our local area, one of the most impactful interventions has been assisting people who have unstable housing needs, for example, and another impactful intervention has been identifying gaps in services and acting to, you know, provide services. So I think that while these things are very hard to evaluate, a multi-agency approach is absolutely fundamental.
Could I speak to this, Alex?
Yes, sure.
Thank you. I think there's a really interesting question here around something Alex mentioned around care planning reactive or is it preventative? And I think that where services are being put in place to help prevent future attendance where possible, not by restricting access, but by making sure that you've met some needs, then there's a really good case for multi-agency working. However, as a patient and as somebody who has lived this over a number of years, I would just raise a really big caution about the routine involvement of police in psychiatric care planning and medical care provision. And I would raise this first just as a question of parity. So if you have a patient like myself who has never had any issues around violence, not have any ongoing contact with the criminal justice system at the time of my frequent attendance, if I'd had an MI or if I'd had, you know, physical trauma as a result of a road collision, would I routinely have police in my medical meetings? Would I routinely have police involved? I wouldn't. And so why is it that for sort of mental health needs that is starting to be done? And the reason I primarily ask that, there's two parts to it. One is that I did an informal survey a number of years ago with over 100 people with lived experience of police involvement to mental health crisis. And the vast majority did not want police involved in the response. And yet that's very different to what we see happening around the UK at the moment. It's becoming much more common that police are routinely involved in the response. Most people wanted a solely healthcare or healthcare and social-based response. And that's very understandable. And I suppose one of the reasons why I understand that perspective so much is because the over-involvement of police in my mental health care, not by me and in my emergency medical care, actually led to me being arrested twice and prosecution. And it wasn't because of anything I had done. It was solely because the police became frustrated around the amount of resource they were being asked to put in. And that had a massive, massive impact on me. And involving people in the criminal justice system is in no way a neutral intervention. It's in no way a helpful boundary, and it causes immense harm. We all know about the types of harms. I'm sure I don't need to explain this to you, seeing patients all the time. So I would just sort of raise a big warning flag about the routine involvement of police. There are cases absolutely where it may be of benefit, but those aren't all of the cases, I don't think, that we're seeing it in currently.
Thanks. And finally, Rian, any comments on multi-agency approaches and preventative care planning during a period of non-frequent attendance?
I think the care planning, or if you're doing any care planning, it's good to do it when in a period of non-attendance. So I think that's a good point. I think multi-agency might not be a popular answer, but I'm not that keen because it's multi-agency is great when you've got the right balance of people in the room. If it's all clinicians and police, then it just says something. It needs to have a balance of. I had a call today about it, and I said, right, reel off who you've got coming to the MDT, and everybody was medical. So I thought, well, you need housing there as a brilliant, brilliant contributor. You need social care. You need the voluntary sector. You need community services, those sorts of things as well. And if we're ever going to align a social response with a medical, then we have to have representation at the table and not have social care or a social response or the voluntary sector feeling inadequate when you're there. So it's got to have that balance and really validate social responses by having them at the MDT. So that's my opinion.
Thanks. And final point related to periods of more frequent or less frequent emergency department attendance is, I think it's important to bear in mind that that doesn't necessarily have any correlation with what's going on in somebody's life. Just because we're seeing them on a frequent basis doesn't mean that there are not other positive things about someone's life. And equally, if we're not seeing or hearing from someone, that doesn't mean that everything is fine. There may well be ongoing problems. So I don't think I'm not aware of any research into the relationship between frequency of attendance and quality of life, but I think we should be cautious about assuming that there is a direct relation. Now, we've just gone over 8 o'clock, so although there are loads of really interesting questions to discuss, I think we do need to let everyone get on, and I just want to thank all of the audience for joining tonight. Thank you for the really important discussion, really important questions. It's been really interesting, and certainly I know I'm one of the presenters, but I've really learned a lot from the other presenters and from the discussion from you all as an audience. Thank you to the audience, and thank you to our speakers, and thank you to our organising panel as well. And let's finish up there. Thanks very much. Bye now.